Good afternoon. It is indeed an honor and a privilege to be here with my Maine colleagues and friends. I'm not known for my pithiness, so I will just alert you to that right now. So I want to introduce, and I pushed the green button. I want to introduce you a little bit to Maine and tell you about the environment within which we're working. Maine is the only state in the United States whose name is one syllable, and we're the only state that shares our borders with only one other state. We have a total of 33,000 miles, and we are larger than all 5 of the other New England states put together. We have almost 31,000 square miles in Maine. Just to give you a comparison point, here in Philadelphia, you have 127 square miles. We have 3,500 miles of coastline, 6,000 lakes and ponds, 17 million acres of forest land, and over 540,000 acres of state and national parks. We have about 1.3 million people spread across 16 counties. The population of Philadelphia is 1.5 million. We have 43.1 people per square mile. And we even have a county that's a frontier county, as some of you do, with 4.3 residents per square mile, versus here in Philadelphia, about 19,000 people per square mile. We birth 13,500 babies a year, which is interestingly the same number of miles that we have for our snowmobile tracks. So that's about 37 babies a day. You have about 23,000 babies birthed every year here in Philadelphia. We are the most white state in the country. We have 3 Native American tribes. We have a growing aged population. And when we think about poverty, we can talk about 1 in every 5 kids in the country being raised in poverty. 1 in every 4 I'm going to mess this up. 1 in every 4 in Maine being raised in poverty, and in 2 of our counties, 1 in every 3 children currently being raised in poverty. So I want to tell you a little bit about our origin. We are a derivative of the Maine ECCS, the Early Childhood Comprehensive Systems Grant. I'm a member of the Maine Children's Growth Council. We've started in 2007, and we advise the governor, the legislature, and the state agencies about policies for young children prenatal to age 5. We do this work through a number of subcommittees, all of which work closely together, some more so than others. I am the chair of the Health Accountability Team, and for the last several years we've worked on 2 focus areas. One is certainly our adverse childhood experiences, and the second area is our comprehensive prenatal to the school door screening. And when I say that, I'm talking not just about developmental screening, but I'm talking about all kinds of screening, including sleep screens and nutrition screens and safety screens and maternal and paternal depression, et cetera. We were fortunate to receive ERA funds in 2011, which funded our ACE study, and I've provided, that is available on a link to talk about for you to download and read. This study was a really wonderful opportunity for us to look at what's happening in the state of Maine around adverse childhood experiences. And what we understand now is that we've got about a 17-year history in Maine of bringing ACES to our state, talking about ACES in different venues and by different stakeholders. We developed a series of recommendations as a result of this study that kind of go into a couple of categories. One is the need for the people who are doing the ACES work or who are interested in the ACES work to have access to a toolkit. Another piece is how do we raise community awareness and education. And the third piece is supporting local initiatives. Part of our challenge with all of this was to figure out just how we're going to do our work. in terms of educating and screening and integrating our work across sectors and developing those collaborative networks that not only get the message out, but also support one another in the work that we do. Okay. There were several take-home points that were really important to us, things that we've talked about all morning. And things that we really believe in. We've been guided by the work of Mark Rains, who we're very fortunate to have in our state. And Mark has done a lot of work and a lot of emphasis with us on talking not just about how many ACEs you have, but how many ACEs still bother you. And of those ACEs that don't bother you anymore, what kinds of things did you do to overcome the impact of those ACEs upon your life? And we've taken that philosophy and that message forward in much of our work throughout the state. We believe that ACEs can last a lifetime, but they don't have to. Our focus is on prenatal to the school door, and our focus is helping parents to understand what their own ACEs are, and most particularly how they may be affecting their relationship with their baby or their relationship in their pregnancy. We focus on building resilience, identifying what resilience is, and then working with folks to promote that, not only within themselves as parents, within their children, but also within communities. This schematic is a little bit about our organization. We started out with the Health Accountability Team really working on adverse childhood experiences, and most recently, with foundation money, created the Maine Resilience Building Network, or MERBN as it's called. Rhymes with bourbon, so that will help you kind of remember that. And so I want to tell you a little bit about MERBN. We've been meeting for about 11 months now. We'll be a year old in June. And we did all the hard work. We did the mission, we did the visioning, we did the coming together, we did the relationship building, and we continue to do that on a regular basis. We meet every 5th Thursday of the month when that happens, so it's not often, and we meet for a whole day. Well, it's hard to get a lot of people together with our busy schedules, right? One of the things that we did with the help of Leslie Forstad, who's also on our team, is to identify a definition of resilience. And one of our groups has actually promoted this through printing cards that all of our sites have to share with folks in their local area. And this comes from Wisdom Commons, and we have permission to use this with them. What we like about this definition is that it links us to relationships. It takes us beyond ourselves, and it emphasizes the importance of not only relationships but also communities. All of our work is predicated on these 5 general principles that we routinely, in whatever venue we're working in, whether that's early care and education or medical or social service, et cetera, we seek to understand the history of ACEs with the folks that we're working with. And we acknowledge the reality of these ACEs for people and with people by talking about what happened to you. Not what did you do, but what happened to you. How are your ACEs? How is this experience affecting your relationship with your child? How is it affecting you in your later life? And what strategies have worked well for you in coping with the ACEs and in overcoming them? We use existing programs and services. Maine, like many other states, is experiencing a tremendous economic challenge. That's one of our challenges. And we really are seeing a definite erosion, I would say, in both the infrastructure and the availability of many of those essential services just when we need them even more. We really are working actively with our Maine Academy of Pediatrics, Maine Academy of Psychiatric Physicians, and also family practitioners to really look at what primary prevention could look like in the obstetric and in the pediatric or family practice environment, and to think about really preventing ACEs with some of our programs and services. Our goals are shared. We do have a couple of outcomes with our funding that we want to achieve by the end of this year. We will go anywhere in the state of Maine and talk to anybody, and I have. I'll talk to 3 people or 35. And I must say, I've talked with a number of groups, from the Ladies Auxiliary to the residency students at some of our finer hospitals, and the response is always the same. It's always a warm and welcome, thank goodness that we were understanding this information more, and now what do we do about it? What do we do about it? We're really looking at fostering prevention of ACEs through the increased use of screenings in different venues, and I'll talk about that in just a second in terms of what some of our sites are doing. We do have collective efforts ahead of us. This is a picture of Dr. Filiti, who was most recently with us this last month, spent a day with our sites, and we really kind of put him on the spot, and I think Dr. Ander will appreciate this. He only had 45 minutes to talk with us, and the rest of the time we talked to him. And he had to respond off the top of his head, and it was a really enjoyable day together, a really positive, powerful learning experience, I think, for all of us. We are using the collective impact process and have been from the beginning, and it's a model that many of our sites are taking to the local level. So this is a schematic of some of our sites. Just let me tell you that we started with 9 partners about 10 months ago, and we have now moved to have 25 partners. These are all different kinds of partners. There are some statewide organizations, some very small, locally based entities, and some larger collaboratives. Several years ago, under an earlier governor, we had children's cabinets that were located in each of the 16 counties. Those have since disbanded, but many of those cabinets are still around, and those people are still meeting. So there are collectives that are talking together. Let me tell you about some of the initiatives that we have here. These are divided into about 7 areas of interest, but we've got a single agency implementing ACEs understanding within their agency who serves people who live in poverty. We have a housing development in one of our cities, which wouldn't qualify as a city, but that's what it qualifies for us, implementing ACEs within a housing development that is a low-income dwelling. We have a school district who's implementing the ACEs screen within their pre-K screening for early childhood. We have work with pediatric and family practice people to implement ACEs screening. We're training professionals, and we're educating community providers and organizations in very dynamic and real ways. And we have 15 new partners that we're currently talking with about becoming part of the MERBN, each of them bringing a skill and an asset and a contribution to our collective partnership. I would tell you that the things that I think are most important for us to emphasize here today is this is an organic movement. This isn't something that started at the state level and moved down. This is something that really came from the bottom up and is just remarkable in terms of its strength and its integrity and its interest. I probably get a call a week from a new site or somebody who's interested in doing ACEs work or who is just doing ACEs work and really has learned about us. Things that we're learning about the need to really talk more about fidelity to our goals and our mission and our principles, and the use of the ACEs tool, and how sensitive that it can be sometimes, and how we're going to ensure that good work is done by all of our sites. These are some of our statewide initiatives that I've talked about earlier. And these are some of our partners who are collective at the local level and also at our state meetings that happen throughout the MERBN. Our prevention work is done through a series of partners that probably you all have at the local level: early care and education, home visiting, Head Start, early Head Start, your early intervention system, and your childbirth education classes and so forth. Our prevention efforts are really going from not only individual prevention, but our issues are, and our interest is to incorporate ACEs more in public policy and more in financing decisions. And I think that we're making great inroads in actually doing that. And that's all I have to say. And I made it in time.
Great. Well, I have the pleasure to represent the American Academy of Pediatrics today. And it was about 16 months ago that the Academy published a technical report and policy statement on toxic stress. And in that report, the Academy basically affirmed that we believe that we really need an integrated, coordinated public health approach to address toxic stress. And while the pediatric medical home cannot do it alone, clearly the pediatric medical home must play an integral role at all levels. So I would say that the Academy's position would be that the pediatric medical home is necessary but not sufficient to address toxic stress. And so we are clearly one important piling, but we were really actively working to try and build bridges with the educational community, with the home visiting community, to try and become a network of pilings. So each year the Academy has a agenda for children that they put out, and I don't have a marker here, but basically the pillars there and the principles around the side stay the same from year to year. They're ongoing priorities for the Academy, but the planks on top, you're not supposed to call them pizza boxes, but that's what they look like. The pizza boxes on top are the things that the Academy is putting a strategic priority for that particular year. And so you can see we have children, adolescents in media, early brain and child development, epigenetics, and the new one for this year is poverty and child health. And so for the bottom three there, they're in a lighter shade of yellow, indicating that they're in the process of being implemented. So there are leadership work groups for each of those. And then for poverty, it's planning, which means we haven't identified the leadership work group yet. But Bernard Dreyer has been leading the charge for that. So what I think you can appreciate is that early brain and child development, epigenetics, and poverty, they're really sort of all talking about the same thing, in the sense that they're talking about this eco-biodevelopmental framework and understanding how the environment impacts upon child health and development. So I think, again, would just refer to Clancy Blair's work, which has shown that stress mediates the relationship between poverty and executive function. And if that's not brain, epigenetics, and poverty, I'm not sure what is. I mean, that goes through across all those spectrums. So for the last year, I've had the pleasure of chairing the Early Brain and Child Development Leadership Work Group. I should mention that that work group was founded and chaired for a long time by Dr. Willis, and I've done my best just not to screw it up. We are a small but mighty group. We have Pamela High, who's a developmental behavioral pediatrician, Colleen Kraft, who's a primary care pediatrician but works with with residency training programs, Mary Margaret Gleason, who's a child and adolescent psychiatrist, Dipesh Navsaria, who's also a primary care pediatrician but does a lot with early literacy, and then Francis Rushton is our board member who's known for his work with community pediatrics. So we are a small but mighty group, and we have a work plan that I think really reflects the Academy's call to action with three main sort of prongs. The first is messaging and education, advocacy, and then practice transformation. So in terms of messaging and education, we're trying to educate pediatricians about the basic science of development, the epigenetics and the neuroscience that I talked about this morning, the urgency of those first 1,000 days of life to try and get things right the first time. And we've tried to utilize a number of different vehicles to get our message out there. For those of you who aren't doing anything in October, the Academy has their national conference and exposition every year. This year it's in Orlando in October, and each year they have a Friday pre-conference symposium they call PEDS 21, which is Pediatrics for the 21st Century. And this year the PEDS 21 symposium will be on early brain and child development. We'll be having Pat Levitt talk about neuroscience and Moshe Ziff talk about epigenetics. And Tom Boyce will be talking about social disparities. Then we'll also have three people talking about how we can translate that science into pediatric practice. So I'd urge you to come if you'd like. And we also have a website that we're trying to drive people towards. It's www.aap.org.ebcd. I was told just today, though, that you need to be an AAP member to get in. So that was a surprise to me. I didn't realize that. So we'll have to look into that. But if you are an AAP member, this is a resource that has a lot of resources at it. Other prong is advocacy. We've tried to work through the chapters because although the National AAP is one very large organization, there are state chapters, and we've been working with the chapters to try and get a public health approach out there. And also, when the toxic stress was before the board, there was some pushback about whether or not we should publish it because the implications were so large for pediatric practice. Maybe we should wait until we have some other pieces in place. And the reason the Academy went forward with publishing the toxic stress policy statement and technical report was because it was an opportunity for advocacy at the state level to say we need to maintain investments in children for a biological basis. And so that sort of carried the day. We also are planning, in conjunction with our Department of Federal Affairs, a toxic stress summit in D.C. In the fall to try and really bring this to the federal level, this advocacy that toxic stress is something we need to try and address in a public health manner, and that perhaps the federal government can play a role in coordinating that effort. And then finally, where the rubber meets the road here is practice transformation. And it begins, again, sort of looping back with education. We need to educate pediatricians about the ACEs and toxic stress in a public health approach, and we're, again, trying to do that in many different ways. We're also trying to empower pediatricians to communicate with families by giving them tools. There's a thing called the 5 R's of early literacy. There's connected kids, there's bright futures. And we're also actively trying to build systems and connections within the community. So again, going from individual pillars to a network of pilings. And then, of course, we're also trying to work on develop a consistent community-wide message. Is there something we can say about parenting, not in the sense of this is the only way to parent, but sort of raising the floor and saying these are the basic parenting skills that we need to provide children so they can have an equal chance at thriving. So, trying to move forward. Oh, I'm going backwards. That's not good. There we go. Okay. So, I began by talking about the early brain and child development leadership work group because that's what I'm most familiar with, but there are many other activities in the Academy that are moving this agenda forward. Heather Fitzpatrick is here today, and she's the staffer at the AAP for the Medical Home for Children Exposed to Violence project. This has been funded through the Department of Justice, in part through the Department of Justice Defending Childhood grant. We've had an international conference. We participated in the international conference on child maltreatment in San Diego. There's a series of webinars that are downloadable from the website at aap.org/medicalhomeCEV. And again, I thought that those were open to everyone, but it may be that you need to be a member of the AAP to access that. I hope not. But the point is that we have ongoing activities through the Academy to try and help pediatricians do a better job of sort of preventing what I think of as this sort of intergenerational compounding of toxic stress, right? And I think that, as much as a childhood advocate, I whine about short-termism and people not thinking long-term. I think that there is now a push to think long-term when we start talking about the federal deficit. And I think the question is, do we owe the next generation anything more than a balanced spreadsheet, right? Do we have any other obligations to the next generation? And I think we can make an analogy there in terms of an intergenerational compounding of toxic stress, just like the federal budget is exploding. I think we can try and use that frame to our advantage. Another example, there's been a trauma guide that's been developed in partnership with the Dave Thomas Foundation. It's available at aap.org/fostercare. One of the purposes of this trauma guide was help families understand that current behaviors may be reflecting past trauma. So the child who now is hoarding, that may seem very odd and maladaptive to a foster family, but that may actually be adaptive from the previous environment where the child came from. And so we're trying to help families deal with past trauma. And through these activities, I think we are starting to move the needle a bit. I think that pediatricians are becoming more aware. Every year, the Academy has an annual leadership forum where they bring the leaders of the chapters and the committees and sections together. So basically, the leadership of pediatrics across the nation for a meeting. They call it the annual leadership forum, and they have resolutions that they pass. And in true David Letterman style, I'll give you the top 10, right? So these were this year's top 10 ALF resolutions. So number 10 was the prevention of button battery injury to children, which is clearly a bad thing. Physical education in schools, non-standard immunization schedules, don't get me started. Monitoring the outcomes of home births, teaching safe parenting skills to students. Sort of surprising. Protecting the health of immigrant and rights of immigrant children so their families aren't torn apart. Promoting social emotional learning throughout infancy and childhood. I guess you can guess where that came from. That came from our group. Cindy Christian was one of the movers behind improved communication between child welfare systems and pediatricians. Bright futures should be required and covered insurance benefit for all children. And number one, reflecting Newtown, promoting education of families about the culture of violence in the media and its effect on children. So the thing I think it's interesting about that, I think you could easily make the argument that the ones in purple here, so 5 out of 10, half of them really are trauma and ACE informed, right? And so I find that very encouraging that the leadership of the academy is getting it, right? And clearly, Rome wasn't built in a day. To empower pediatricians to address all these things is not going to happen overnight, but I think through education, advocacy, and practice transformation, translating the science into practice, we're going to get there. And of course, there are other activities through the academy, probably more than I could name in 15 minutes. But again, we have Bright Futures guidelines for health supervision that allows pediatricians to do a better job of anticipatory guidance. Thanks to David Willis's leadership, there has been a Building Bridges grant to the academy to try and build bridges between the pediatric medical home and home visitation early childhood systems. There is a community on early childhood. There's a section on early education and child care. There's a community and section on child abuse and neglect. There's a National Center on Health for Head Start that's at the academy. And there's this National Center for Medical Home Implementation. So there's a lot of things going on, and that's part of the reason why the academy wanted to have a leadership work group. They're trying to coordinate the early brain efforts. The thing about those planks and pizza boxes that I started talking about, they're a short time limited thing, usually 3 to 5 years, and they go away. And so the early brain leadership work group that I'm leading is about to go poof. But the academy has recognized that there's a need for this. And so there's been a movement at the academy to have a new center on something, and it hasn't been named yet as an official yet, but there is a movement to have a center on sort of the early childhood origins of wellness and resilience. And so I think that's sort of what we're talking about today. I think the academy recognizes that to successfully prevent adverse child experiences and toxic stress, the pediatric medical home of the future will need to play an integral role, and we're clearly one important piling. But I think it also underscores sort of a sea change in terms of the way pediatricians need to practice from sort of monitoring and supervising problems to perhaps being a little more proactive and preemptive in terms of building resilience and actively building wellness. So the academy is working every day to try and educate and support the medical home as they try and rise to meet this tremendous challenge and opportunity. Thank you very much.
Hi, everyone. I'm Nancy Hart from the University of Florida College of Medicine. And let's see. Do I pretend I know what to do with this?
Just the green button and it goes forward.
Okay. And I was asked to talk a little bit about putting ACES into the curriculum in medical school, and I thought I'd start with the story about how I ever got into this gig, because sometimes that'll inform you why I'm in this crazy place. So when I left for Memphis, Tennessee, right after 9/11 to direct an Institute for Women's Health, I'd never heard of ACES. I didn't know anything about it. And while I was there, a number of things changed my thinking about the world of OBGYN, pediatrics, public health. One of them was that I read the book, Jack Shonkoff's book, Neurons to Neighborhoods, and he came to Memphis to speak. And then someone came to talk about Fleety and Nanda's work. I don't know if it was you, but it was a very cool presentation where I felt like, that scene in Mars Attacks when they hear the stupid Rudy Valley music and their brains explode. I felt my brain explode. Like, how could I have been a doctor all these years and not known this stuff? I would have been such a better doctor if I had. So I started getting this idea in my mind that I needed to learn more about policy, and then I needed to teach it to students and residents. So the University of Florida has 50,000 undergraduate students. I guess it's bigger than some of the counties in Maine, huh? Yeah. And it turns out that we also have just about the largest number of minority students who want to enter health professions. Isn't that interesting? Would you have ever guessed that? So I took it upon myself to try to create a pipeline between those minority students and our medical school, because our medical school increasingly was wealth and privilege white kids. And not that I don't love them, and not that I don't think they can make great doctors, but I just don't think they reflect the population of our state. And when students do come to the class, it's really nice to make them understand that the patients they're going to be taking care of didn't always have those same privileges. So my very favorite slide to start with whenever I talk to medical students or undergrads, because we have created this pipeline now, is this picture of the cosmos, and I tell them about the cosmic lottery. And I explain to them that you did not get to pick your parents, and you all, because you made it to medical school, must have had some amazing parents or some amazingly resilience-building adults in your life who sat you on their lap, showed you books, talked to you when you were little, told you were cute, smart, funny, talented. I love the way you play baseball. I can't wait till your saxophone conference, or, whatever. So, and there are children in our community who had none of that. All they ever heard was, you're fat, you're stupid, you're ugly, sit down, shut up, we wish you'd never been born. And the students kind of get a little wide-eyed right at this point, and they begin to be thinking that I'm really a crazy lady. So this is when the lecture may spin out of control, or it can get really good. So what I hope gets it really good is I show Maslow's hierarchy. And I always ask the class, how many of you have ever heard of Maslow's hierarchy? And the answer, about 10 to 20% of students raise their hands. And I've asked them where they heard of it, and the students who heard of it are the ones who either took a psychology course or a social work course. Really, there's nowhere else in undergrad that professional students are going to get this information, so I present it for the first time to them in medical school. And I start at the bottom, and I immediately start talking about the ACEs at every level, because really that's what this is. And the other thing I say is that self-actualization, as Maslow described it, is a transcendent, the ability to transcend, a transcendent activity that you become capable of if all these other basic needs are met. And I say, I think that's too hard to explain, so let's just rename it parenting. And think of it this way, that if you self-actualize, your ability to supply these things to your child are met. And that explains why a 16-year-old may have trouble being a really good parent. Not that they're innately poor parents, but how many of them have had a chance to have their sense of belonging achieved and their self-esteem and their sense of respect fully developed before they became parents. Are you with me? Yep. So then the other thing I do at the end of going through all of this and mentioning ACEs at every level, but I haven't really talked to them about ACEs yet, is I say, okay, so let's talk about, for 1 second, let's think about what it takes to be an effective parent. Do you have to be wealthy? No. Do you have to be any particular race or ethnicity? No. Do you have to be married? No. Do you have to be heterosexual? No. And by the time I get to heterosexual, this is Florida, a very conservative state. Their eyes are bugging out of their heads. She's truly a crazy woman. But I have had, after every time I give that little spiel, I've had at least 2 students come up to me and say, this is the most important thing I've learned yet in medical school. So you know what my reward is for that? They took it out of the curriculum. So the battle's never over. So then after I talk about Maslow's, I begin to talk about ACEs, and I show a little bit of the work that I just basically stole off the cdc.gov website. And I must say, if you care for any of this information, I encourage you to steal it. I don't even care if you don't attribute it to me, because I think everybody should be learning this stuff. So I like to show this particular combo of pictures that I didn't put together, you guys put together, because when we do autopsies, I'm an autopsy pathologist, the first thing you do is look at the body and make a comment in your report whether you think the body appears the stated age. And believe it or not, there are a few people that look much younger than their stated age, but most people look their stated age or older than their stated age. And I think that's exactly what's being shown here, is that infants pretty much look their stated age. But by the time we reach adulthood, a certain number of people appear older than their stated age. And all of you clinicians know exactly what I'm talking about. And those are the people with the highest ACEs. Ask them. You'll figure it out. So then I show them this data just to show in contrast to what I'm about to show next. And I like them to know that in the Kaiser Permanente, insured, middle class, employed, mostly white, had some college, a pretty middle class group of people, about a third of people or more had no ACEs. And then in contrast, I show them the juvenile justice population in the state of Florida, where only 1.2% of all the children in our DJJ system have 0 ACEs. And then they begin to see how perhaps their ACEs may be even less than the Kaiser Permanente insured, because by then they've already ticked up their own number in their mind. And now they compare that to the DJJ kids, you know what I mean, the children that have been arrested and are being adjudicated to determine whether they are going to be free or go into juvenile detention. Then the next thing I did was, this map didn't exactly come out like I wanted it to, but the next thing I did was create some maps for our community showing where health disparities concentrate, because when I teach about ACEs, I do it at the same time as I teach about health disparities. And health disparities, as we learn it in medical school and as we teach it to medical students, is conflated with race all the time. And I never, ever, ever talk about race when I talk about health disparities with them, because I think it's too easy for children that come from wealth and privilege to think that's someone else's problem, that's not my problem, I don't really have to wrap my brain around it, they really deserve it at some level because I pulled myself up by my bootstraps. Does any of this sound familiar to you? So I don't really go there, but they actually get it by coming in through the back door. And I created this map. So if you imagine around these blue stars, there are actually densities there, which would go with these, this color rainbow at the bottom. We were actually able to show where there were concentrations of Medicaid births in our community. And we actually started a mobile clinic that goes out to all those neighborhoods and offers primary care services. And it wouldn't shock you to know that the 2 most common things requested by patients who see the bus in their neighborhood and walk to it, no appointment, just walk in. 2 most commonly requested services are testing for sexually transmitted infections and, shock, family planning. So people who live in these neighborhoods where there are concentrated moms who are giving birth into poverty, they do not want to have baby after baby. It's just very hard for them to get to family planning. If you make it easy, they will use it. So then when I had that map, I showed it to a lot of people in town. I call it flapping it in front of anyone who will listen. And one of the people I flapped it in front of was the county sheriff. We happen to have a woman county sheriff. She's extraordinarily progressive. And she said, "Oh, Dr. Hart, this map is so interesting. Would you like to look at my map?" And so when she showed me her map, this little area that's shaped like a triangle with an M in it corresponds perfectly, perfectly, perfectly with the highest density of Medicaid births and premature births in our community. And I said, "Sheriff Darnell, do you mean to tell me that the place in our community with the highest concentration of mother-baby pairs is also the place in our community with the highest concentration of crime?" And she looked at me, and I looked at her, and both of our jaws flew open, and we said simultaneously, we got to do something. So that actually started a community movement because of these maps. So one of the next maps I made, this is what the other one would have looked like. That's those pretty purple spots showing you where the medicated births were concentrated. No shock, child maltreatment was concentrated in the same place as the Medicaid births. And then using the sheriff's data on calls for domestic violence, no shock, domestic violence was also concentrated in the same place. So we kept finding that the hot spots were all superimposed. And then when we went around the community, each of the community partners said, "Oh, I never knew that was a hot spot for Head Start. Wait a minute, maybe that's why I have so many kids on the waiting list in that area of town." Or someone else would say, "Oh no, all our hotspots on the east side of Gainesville. Wait a minute, we looked at our data. It is on the west side of Gainesville." So it turned out that everyone knew about these spots. The sheriff knew about it, but the OB department didn't know about it. And once we started showing these maps and people started creating a collective consciousness, everybody got interested in these neighborhoods. And so did our students, circling back to education. So when I showed these maps to our students, I started with the undergrads. Remember I told you we have 50,000 undergrads, 700 student service organizations. They all have to do something fantastic in our community in order to get their little crumb of money from the university to be a club. Oh, they were all over it. They were all over it. They said, I want to go to that neighborhood. I want to provide after-school programs. I want to do this. I want to do that. And so we got a huge involvement of our undergrads doing service learning in these neighborhoods. So what would be suitable audiences for this kind of spiel? You guys know this spiel. You could do this, and I'm sure you are in your own community. But what we found were that all of the medical student courses that relate to something like population health, behavioral health, peds, family medicine, and electives and community outreach would sit long enough for me to get some of this out. Maybe not a whole hour, certainly not a series, but if I could do 1 in year 1 and 2 in year 2 and 1 in year 3 and 1 in year 4 and show the cosmic lottery picture at the beginning of each one, eventually it begins to string together in the students' minds. So for example, how much time do I have left? 2 minutes? Okay. So for example, in community health and family medicine, they've already had most of their clinical rotations, they've been to the clinic, and are any of you family physicians? It's pretty frustrating sometimes, right? So I asked them after community health and family medicine, describe to me your most frustrating patient. And I'll go around the room, and it's going to be the same thing every time. Drug-seeking behavior, chronic pain, chronic depression, obesity. Those are always the first 4 that come up, and then there are usually a few other things that are not so directly linked to ACEs. But then, after I review with them what the ACEs are, they all begin to nod their heads that, oh yes, the patients that vex me the most are the ones with the most ACEs. And wouldn't it be nice if every community health and family medicine practice had a social worker there, where you could ascertain these problems that are wearing you out as a physician, that are making you feel bad about yourself, and then put them in the hands of someone who really knows how to probe more delicately into these problems and do a quick intervention or maybe a longer intervention, including a psychological intervention. Our pre-professional students, as I mentioned, we managed to create an undergraduate minor in health disparities. It is oversubscribed every time it's offered. Don't ask me why, but students want to learn about health disparities. These are undergrads now, college students, freshmen, sophomore, juniors, and seniors. And then they made our intro to health disparities one of the fulfilled a requirement that they need for everybody, and we had to double the size of the class. So we have 100 students every semester learning about health disparities and ACEs. And then for community groups, we took the maps that you saw and we mounted them on foam core this big and take them out to community meetings and put them up on easels. So I flash them up here and then I give people time to go look at them. And then they're going to go look for their own neighborhood, right? They know where I-75 is. They know where Waldo Road is. They know where 13th Street. They know where the university is. And then they find their neighborhood. And that's when stuff begins to happen because they can personalize this problem. So I guess one of the things that we could do as a group is think about ways that we can get local data that will energize local people, because obviously many of these solutions are going to be at the community level. Okay, and that's my time.
Good afternoon, everyone. I am Marcia Stanton. I'm with the Phoenix Children's Hospital. I coordinate child abuse prevention programs. I have to say, I don't know if I'm starstruck or awestruck or something, but I'm just, I'm so excited to be here with all of you. And particularly, I was actually very happy and thrilled to be invited, but then when they asked me to speak, that would put me over the top. So I'm going to tell you a little bit about some of the things that we're doing in Arizona. And, many of you probably think of Arizona as this backwards, kind of crazy state. And in a lot of ways we are. But I think in terms of, our response to the issue of child trauma, that we're beginning to do some important things. So I'm just going to tell you a little bit about our ACE consortium. We have a statewide ACE consortium and how it really started. For me, somewhere around 2005, I just happened to stumble on the original research article. And when I read it, I was kind of dumbfounded, and I thought, well, this isn't new research. Where has this been? I've never heard about this. And I just kept going back. I printed the article out and kept reading it and thinking, this is pretty profound. We need to, people need to be talking about this. So I invited Dr. Folletti, and this is a picture of him when he came to Phoenix Children's the first time, I think in 2006, because I thought, oh gosh, pediatricians really are going to be excited to hear this information. So he came as one of our activities for April, as Child Abuse Prevention Month, and he did a morning grand round. So we had about 100 pediatricians in the room, and I was just thrilled to have this occur. And the response was total lack of affect. I mean, there were literally 2 questions that came up after what I thought was this profound presentation. And one was sort of trying to sort of pick apart the data, and the other one was kind of a joke, maybe we should prescribe ACE inhibitors to everybody. And then everybody filed out of the room, and then for the next couple years, my efforts with our medical education staff to really talk about this went nowhere, because they said, well, you saw the response. We're not interested in pursuing that. So we sort of set that aside for a while. That same day, Dr. Folletti gave a similar presentation at a community leaders luncheon for about 100 community leaders. And there was a little more interest there. And there were a couple people that came up to me after this presentation kind of with the same feeling that I had initially and said, wow, this is important. We need to continue this conversation. So this little group of us started, meeting occasionally, and a woman who's a professor at ASU, the 2 of us started speaking to anybody that would listen to us at different local conferences or wherever it was. And it seemed every time we talked to a group of people, we would sort of pick up a couple people, and they were interested. And we felt a little bit like the Pied Piper, hoping that we weren't going to, lead everyone into the sea or off the cliff or wherever they go eventually. So from that, just bringing together these little groups of people, in 2007 we said, we have to do something a little more structured. We brought Dr. Folletti back and did a smaller roundtable event. And from that event, it was about a half day, there was sort of a core that agreed that, yes, we need to do something. So that became the basis for our ACE think tank. And we called ourselves a think tank because we had no idea if or what we might do with this information. And I didn't want it to just be another task force or committee, because then people start to lose interest right away. And we didn't really know. So we would just get together periodically and talk about this. And initially we spent a lot of time talking about data. And we didn't really have data. And I felt like, we sort of got past that and started working on some different things. So we have been meeting somewhere along the line, maybe 2008 or so. We needed some funds to do some things. So we said, well, we better give ourselves a more, official name. So we became the ACE Consortium. So what started from a handful of people now is at least 200 people regularly that get the communications. We don't have that many, obviously. We meet just on a quarterly basis, and we have anywhere from 15 to 50 or 60 people at our quarterly meetings. So we started to get organized. We did some strategic planning. You can see our vision statement. Basically, our 3 main goals are education, expanding collaboration, and promoting evidence-based prevention and treatment. So I'll tell you, most of what we did was, as somebody else mentioned, sort of organic. I call it by the seat of our pants. We felt like we had to do something. But obviously, we looked to the research. We tried to work in a somewhat logical fashion. And so these are some of the places we went early on to help guide our work. So I'll speak a little bit of each of our 3 goals. The first one, in terms of education, I mentioned we just started talking to anyone that would listen. We recognized pretty quickly that we needed some print materials. We needed information that we could leave with folks about our consortium and about our goals. So we developed brochures and some posters, and I'll show you some examples in a few minutes. Since about 2009, maybe, I do orientation with all the new clinical staff at our hospital. And so I spend 30 minutes talking about ACE study and child trauma. And to this day, I still have whole classes of new employees that have never heard of the study. I mean, now there's a trickle, but it astounds me that, and many of these are experienced professionals that are just new to our hospital, but many folks still are not aware of this information. We've done some community events. When Tanya Kane was in town, we did a film screening and discussion of Healing Need. Probably in terms of education, the biggest thing that or where we're spending the most time is through our Train the Trainer program. We started, I think our first one was in 2010. It started as a 2-day training, and we realized that was, we just didn't have that much time to spend, or individuals didn't have that much time to invest. So we cut it back to a 1-day training. We have trained, we have ones coming up in a couple weeks, so when that concludes, we'll have about 300 trainers around the state. We give them a toolkit with the goal of them going back to their communities, and they're obligated in exchange for our free training and the toolkit to do presentations within their community to anybody that they is interested in listening. So it could be the faith community, it could be, one group now in the northern rural part of the state on the Navajo Reservation. They present the information at their annual sobriety powwow. And they've actually, one of the trainers there redid our toolkit materials so that it was really more culturally appropriate for our Native families. And that's what we really stress in the training, is this is just some basic information, but individuals need to adapt it to their communities, because the communities, as we've heard several times today, is really where a lot of the work and the changes need to start and occur. You can just see some of the elements of the what we include in the education. So that, and in terms of our second goal, expanding collaboration, our group is certainly multidisciplinary, and it includes many different systems, private, nonprofit, advocacy, peer support and recovery. We have individuals representing those communities, and I think that has been a terrific addition. We didn't have that early on, and they certainly bring a great perspective that we need to hear. I think, generally, I think our hospital it's sort of a neutral agency or organization. So people, I think, we're okay with joining in. So and this didn't start out this way, but we now have, in terms of our government agencies, child welfare, public health, behavioral health, early education, juvenile justice, because a lot of what our consortium is doing is meeting the goals that these individuals' agencies have. So we're providing something that they really need, and they're very interested in being involved. One of the exciting things that we've done a couple years ago was partner with our local PBS station, and they maintain a website for us, and the web address is there. As a part of our partnership, a couple years ago, the PBS nationally had a 2-year project, This Emotional Life, which was a series of a couple specials and then some outreach. So they wrote a small grant to their national office to support some of the things that we were doing. Anyway, so we did a primetime Ask a Child Trauma Expert, where we had a panel of local individuals being interviewed on this show, and at the same time we had about 30 mental health professionals in the studio answering phone calls from viewers about certain, about concerns. That was, I think, was pretty profound, because it was all of the callers basically had the same message. Number one, they were overwhelmed that people were talking about the topic, and that they wanted to hear and see more of this. PBS loves it because often the local programming doesn't even reach a level where it, gets ranked on the Nielsen ratings, but this special did. I mean, it wasn't huge, but it jumped it up. So they're anxious to partner with us because it meets a lot of the goals for their organization. We also, the last couple years, started doing quarterly newsletters and fact sheets, and each one has a different topic. The last one was for educators, and was sort of a general newsletter, and then we have a couple companion pieces, one for parents and one for professionals. And that gets pushed out to really thousands of people around the state. Just with our connection with PBS, any of the things that we do with them, they push it out to over 73,000 educators around the state. So a lot of people are hearing or getting the information. We do a little bit on Facebook and Twitter. We're trying to get that going more, but we have a long ways to go. In terms of promoting evidence-based prevention and treatment, we certainly support all evidence-based programs, but in particularly we're putting a lot of effort in PPP, because assuming child trauma is a public health issue, we think that it makes sense to have a public health response, which is what PPP does. If you're not familiar with a whole series of levels of intervention, it's very cost effective. The investment, financial investments, there's a pretty quick return on your investment. They impact rates of substantiated child abuse, out-of-home placements, new behavior problems in children, all really important areas that some other programs don't necessarily get at. We have, I also facilitate a statewide PPP planning group. So we have a large group of people around the state trying to, we actually have a plan developed. Now the second and more interesting step is we need about $20 million in order to implement it for all families with kids 0 to 12 around the state. I think we're going to get there. We've got a ways to go, but we're finding a lot of support from some unlikely partners. So we're really, and of course, again, we support lots of other programs, but we're putting a lot of emphasis on this. We actually, work on a shoestring budget, which means basically no budget. I'm a part-time person with 100% grant funded, and I'm involved in any number of other initiatives. But we get a lot done on not a lot of money. And we really have the stone soup approach to funding. Nobody really has the money to do all these things, but when we've come up with something that we really wanted to get behind, everyone jumps in. PBS wrote the grant, it just happens. So that was something that was very pleasantly, a surprise to me. What else? I know I'm running out of time. I just want to share a couple examples so you can sort of get a look of some of our things. These were some of our early posters that we developed with our tagline. And I might mention the tagline that strong communities raise strong kids. We came up with that based a lot on the work from the Frameworks Institute about how to talk about issues to really move help move in a positive social change area. The Child Wellbeing Summit, we just had that a couple weeks ago. Again, PBS got a grant to put that on. We had 200 folks from around the state in the PBS studio for a day-long conference. It also was live streamed, and we had a number of, a couple hundred people that viewed it live, and also stayed on pretty much from the beginning to the end. So I think that's always a good sign. The parent resource is something that we're working on. This is just an example of some of our newsletters. Are we making a difference? I don't know. We don't have data to support that, but we do know that we're achieving some of our goals in terms of education. There is a unified prevention message statewide. We've got lots of local trainers working within their communities, hoping that communities can design their own solutions that make sense. And to me, the biggest thing is the ongoing collaboration from a pretty wide array of organizations. And basically, some things we're learning. There's lots of interest. I've been hearing that all morning. This is something, it's complicated. It's going to take all of us working together, but there's real synergy that happens when that occurs. And also that you've got to be in it for the long haul. You've got to be willing to stick with it. Some of our goals you can see, and I was so excited to hear some of the things happening with AAP, because I think that when the physicians and pediatricians really sound the alarm, as they have been doing, things are going to move much more quickly than they have in the past. We maintain an ongoing wish list. I marked 2 things off that wish list. One, after being here today, which is the national conference, which is one of the things we've been hoping for several years. And just some other little things. We hope that we'll have a White House conference or a Surgeon General, take a bigger way to address this. So that's it. That's from Arizona, my report.
Thank you. The brownie, yes, okay. Gonna get done on time. Good afternoon. My name is Sunny Vierling, and I am from Iowa. And we've been doing this work for a couple of years now. So we're kind of, I would imagine, if you look at a life course model, we're in that toddler that just takes off running because they just learned to run or walk. And so some of you are kind of helping pull us back and support us and when we fall, and we appreciate that. Especially I want to give an acknowledgement to Laura Porter from Washington, and obviously Dr. Anda, and our other partnering states that we still talk to a lot through kind of an informal interstate learning collaborative that we started, and that's Wisconsin, Minnesota, Illinois, and so forth. And so some of what I'm about to share, really we aren't ashamed by stealing some of that work and sharing it. So for example, with Arizona, we have the tagline, ACES last a lifetime, but they don't have to, on our website. So thank you for that one. But what I'm going to share with you really is kind of focusing our work. The question was about policy and advocacy. And so that's kind of a roundabout way of how we're getting there through impact priorities that we've structured our work around. But before I get to that piece, it was around February 2011 when some of us at the Mid-Iowa Health Foundation and myself at the Iowa Department of Public Health, we heard Dr. Anda speak on ACEs, and we kind of call it that ACEs vibration effect, where you just kind of come out going, this is the upstream, this is the upstream. And we just realized we have to start meeting about this and figure out what those next steps are. And Dr. Anda also kind of laid that out as a recommendation, is to look at your state BRFIS and the surveillance data that we could add that ACEs into. And so that was really our first step around our work in Iowa. And so you'll see that we first started with what's called the Central Iowa ACEs Steering Committee. And with that committee, we decided we first needed to invest. We needed to invest in that research. And the research really is critical in what's kind of queuing up the movement and the momentum forward in Iowa. And as we were doing the research, we knew that was going to take a while. We were able to add not only the ACEs module, but also mental illness and stigma, which really look at days of anxiety and depression and so forth, and how that'll be integrated into our state BRFIS information. But at the same time, we said, okay, as we're doing the research, and we're going to have a summit, which we started with informing, that was another key piece. So we had the research that was starting to be gathered, but we knew, and through this co-investment of foundation dollars and public health dollars, and public health is, really literally, I passed a hat to bureaus saying, got $2,000 that you're not spending this year? We got some great stuff you can use with that. And so we were able to do this co-investment together. And so as we're waiting for the research to be gathered, we said, well, we also need to inform. That is critical. Because in order to really move this forward on any kind of policy level or engagement as a mass kind of information across communities at a state level and a local level, let's do some informing. So we hosted a summit last year of approximately 800 folks. and representing around 80% of our counties, out of 99 counties. And there was just a momentum that really caught fire. And we also had some of our partners from other states there too. So that was exciting. But the key piece to all of this as we were working on this is after that summit, we said we need to step back and do some visioning, because it's really that visioning of being as intentional and purposeful as we can be, because you can take this and just keep running with it without also making sure that you're being intentional around how you want to use this information. So we had a visioning meeting, and it was very, I think, informative for us in terms of what challenges that we were starting to identify that were starting to pop up as a result of that summit. We found that some of those challenges really were how to keep folks energized and engaged over that long haul, knowing that this is an intergenerational transmission of what we're going to keep working on to stop that. And so it's going to be a long haul kind of approach. And that everyone was looking for this silver bullet, that, well, what's next? What can I do? And we are saying our role is to hold the space for that. We don't want to tell people what they can do in their profession. We just want to keep educating and informing until they can figure out for themselves what to do. We also were taking a leadership role, but we didn't want to assume that role, that there was a balance that we recognized that we needed to find, and that we didn't have all the answers. And that there are definitely more groups that we need to connect with. We are a steering committee that's focused on central Iowa, and yet we have a state level component as well. Myself is one, and we have other folks too. And knowing that the BRFIS information is also at a state level. So we've got local folks that know what's going on at the local community, and they're across disciplines, which is pretty exciting. So we represent around 14 organizations at a state and local level across disciplines. And then we knew that we needed to engage, that was critical as a piece to it, and then the advocate. So I'm going to kind of go through a little bit of these. You can see these are our investing priorities, and these are the folks that are really kind of at the table providing either investments or some of the collective impact partners that are also helping with some of the other work that we've identified. And so our research is really that 2012, and now we also have the 2013 ACES BRFIS data collection, and then we did an RFP for that analysis because we knew that that was really going to be critical to keep engaging and informing and educating. So as we were doing that at the summit, and since then, we've been invited to all sorts of statewide conferences at various disciplines, and they've asked us about that. They're so excited. When is the data going to come out? When is the data going to come out? It's like we're queuing them up, which is exciting. And so what we've said is, well, we're going to have another kickoff event in October. We hope you'll come, tell your colleagues, and then we want to have some roundtables at that summit that will kind of discuss what they can do with this data in their own area and wanting to share that information. So the research is really key. Informing, in addition to the summit, then we had a lot of requests for presentations. We can't get everywhere. Just like Dr. Andy can't get everywhere. And so we have 2 standard ACES PowerPoint presentations, very basic, that people can use. And we've also developed this iowaaces360.org website. It's kind of what we're considering or using as our communications hub across the state. So we're asking any of those other communities that are doing something innovative or around something, for example, with school nurses or with doctors, to let us know so we can put that on the website, and then folks can learn from one another. Or at least who to contact. We don't really want all the things that they're doing because that can get just a point in time, but as far as who to contact for some of the general areas that they're working on. We developed an ACES brief document that was distributed not only at our summit and on all the places we speak to, but also to legislators as well. And then this is pretty exciting. The green, I'm sorry, I should have said the white are the things that we've done. The green is what we're planning on doing. So the green, we're working on an online learning module development. This is through our McVie funds, the Maternal Infant Early Childhood Home Visitation Program. They have millions of dollars and they have to spend before September 30th. So hello. So what they've done is they're putting up lots of money to develop an online learning module that we are working with an organization out of Atlanta called Quality Assist. And they do this really interactive, fun, not just PowerPoints that you have to click through and you take a quiz at the end, but it's really interactive, adult learning kinds of concepts on ACES and prevention. Those are the first two that we're going to be doing. It'll be free. We want to make it accessible to anybody. And then neurobiology of stress, and we want to get experts on that, content experts. And then resiliency and trauma-informed care. Those are to come. But just to get the message out there, that educate, educate, educate. Then we're having that, as I mentioned, the ACES Summit and then the Iowa ACES Data Report. And that one will be really consumer-friendly. So our RFP, the folks that are contracting, or we're contracting now to do the analysis, they're also going to develop a publication that will be very layperson-friendly, so anyone can take it and share it with their community members. And then engage, as I mentioned, we started with that central Iowa piece. We also said, okay, we're doing some of these state level activities, but we also want to know what's going on locally within our tri-county area, which is kind of central Iowa. So we did kind of an ACES readiness assessment of 23 kind of the natural partners of family serving systems, of finding out what are they doing with ACES right now? If not, what would they want to do? What kinds of support would they want to have in order to do what they want to do? And then I've mentioned the Interstate Learning Collaborative, and so many of you could probably do that in your region. It's really exciting. You can learn a lot. And then focused coordination with some of the natural stakeholders in this group. An intrastate. So we're starting to do kind of an informal, as we're moving into next year, an intrastate learning collaborative. As we go across the state, there is some great stuff happening at the ground level because they also have that ACE vibration going on. So it's really been fun to learn from one another and to keep sharing that. And then we hope to identify additional partners at the 2013 summit. And then for advocacy. So all of this really has to move into advocacy, but it's really, that's where we're also very attuned to wanting to hold that space. We've been kind of gun shy in terms of telling legislators and department directors what to do with this, because we want them to decide and to figure that out, and yet we just want to keep giving them information, with the exception of they can certainly fund the ACES module in our BRFIS forever. We'd love that. That's one that's kind of a given. But so we developed this policy brief that was kind of pre-BRFIS data. It was from our BRFIS information, but not with the ACES added in, of just kind of given this information from the national study, and given what we know our kind of like what Oklahoma did, given what we know what our population rates are, this makes sense. This is why it's important to keep looking at this. And then I won't go into all of these things, but it was just the legislative committee, I do want to mention, we had an expert talk about, we were able to get through our committee folks that have connections with the Capitol people that schedule, who gets to talk at committee meetings. And we got on this human resources subcommittee. And we had someone that spoke about the framework of the ACES study, and he had credibility. He was the director of a behavioral health center affiliated with a hospital in Iowa. And so he provided that framework. Then we had a mom speak who was absolutely phenomenal and so articulate. And she talked about being an adoptive mom, of the experience of her 2 children. And they got a standing ovation. And we heard that was the first ever that any of the advocates in that room had ever seen that, because she put a face to it. And she did it in a way that talked about ACEs, but there wasn't blaming. It was all about opportunities and what we could do as a state to address this and not re-traumatize our children. So that just got a lot of traction in terms of advocacy. And then from there, the cool thing was the legislators then started putting pressure on the Department of Human Services director on, what are you going to do about this? And so he kind of, then the great timing of it is that the United Way was, their day on the Hill was the next day. So he asked them, what should I do about this? And so we were able to have some contacts with him regarding some ideas, but again, not telling him what to do, but here are some opportunities that we know that's going on within the Department of Human Services. We also did a one-on-one small meeting with Laura and Dr. Ando when they were in town, with our Department of Education director and Department of Public Health, and some of the hires up within the Department of Human Services. Just again, it's educate, educate, inform, and they got excited too about the possibilities. And then you can see some other areas that we're dialoguing in terms of trauma-informed care for educators related to suicide prevention. These were things that came from a legislator who attended the summit. So they're like, what are you going to do about this? What are you going to do? We're like, what do you want to do? What do you want to do? And I got to give a shout out to Minnesota because they've done this Legislative Leadership Institute that is fantastic. And my understanding in talking with Jane earlier today is that there's now a bipartisan bill on home visitation to prevent child abuse, correct? And that was after directly attending the Legislative Leadership Institute around where Dr. Anda was there and all sorts of other researchers on child development. And so there are possibilities that are endless. And I think I was going to talk with you, but I don't think I have time. I'm sorry about that. But I also had been asked to talk about my hat, where I have the ACES hat, and then I also have another Department of Public Health hat that I put on top of. I don't take one off, I put it on top of, so it's the core within it, about addressing ACES through primary care and public health partnerships called First 5 Healthy Mental Development. And it's all about bridging systems of care and how you assess for family stress and caregiver depression within those well child visits, and then we connect them to services in the community, and we're seeing lots of results with that as well. So, thank you.